Good evening, everybody. On behalf of Dr. Hanadi and Team Qatar National Dementia Plan, and Dr. Khalid and Team Hamad International Training Center, it gives me great privilege in inviting you all for this milestone moment in Qatar's dementia journey. We are having our first nursing webinar on dementia, which is hosted by QNDP HITC collaboration in this very auspicious moment of World Alzheimer's Month. Our journey of collaboration of QNDP HITC started approximately 2 years back under the leadership of Dr. Hanadi and Dr. Khalid, ably guided and supported by Alzheimer's Disease International. Notable support from ADI Regional Director from Asia Pacific region, Ms. T.Y. Suharia. Over this period of journey of collaboration, we are blessed. We are blessed that we have 11 national dementia master trainers who have joined us. And today, for you all, the 11 national dementia master trainers, they have together woven a string of dementia pearls filled with knowledge and information. And they are here today offering it for you all. A special thanks goes to Dr. Sonia and Ms. Jessica in ensuring and making this event a reality. Nursing fraternity plays a pivotal role in every clinical condition. But in dementia, they play a more precious role. They become the memory of the person with dementia. Here's wishing you all an enriching evening of memories. Thank you.
Good evening all and welcome. Allow me to introduce myself. My name is Ria Tocino and I am one of Qatar's national dementia trainers, and I am the acting in charge of Romaila's geriatric OPD services. So today we will be taking you all on a journey to one of the highly talked about medical conditions across the globe, which is dementia. So for the topic of today's talk, it is Journey Through Dementia Diagnosis, a Nurse's Role. So I will be starting the presentation with introducing dementia to you, and as we move along the slides, we'll be talking more extensively about it. Okay, so let me just share my slides. Okay, so introduction to dementia. So I have none to disclose in this presentation. The learning outcomes for this session is that by the end of this session, you should be able to know the definition of dementia, identify the different types of dementia, and identify the modifiable and non-modifiable risk factors of dementia. So, what exactly is dementia? Dementia is the term used to describe the symptoms of a large group of illness that cause a progressive decline in a person's cognitive functioning of sufficient severity to interfere with their daily functioning. So when you focus on the underlying words, when a person starts to experience two or more of the signs of dementia, and it becomes progressive and it starts to interfere with their daily living, that person may be having dementia. So what are those signs and symptoms? What are the 10 warning signs of dementia? First, we have memory loss. Second, we have difficulty performing familiar tasks. So for example, you're used to operating your television set at home. You're using the remote control without any difficulty. And then later on, you start to notice that you're having difficulty identifying the buttons in the remote control. So this is an example of difficulty performing familiar tasks. So they may also have problems with language. Persons with dementia may have difficulty maintaining conversations and articulating the words that they want to say. Disorientation of time and place, poor or decreased judgment, problems keeping track of things, misplacing things, changes in mood and behavior, trouble with images and spatial relationship, and withdrawal from work or social activities. So moving on to what are the types of dementia. So we have here the first one, Alzheimer's dementia. So it covers 50 to 75% of the total diagnosed persons with dementia. So what exactly is Alzheimer's disease? So Alzheimer's, this is it is being caused by the presence of protein deposits in the brain. So this causes cell death or death of the neurons. So the neurons are actually responsible for the transmission of brain signals within the brain. So here in Alzheimer's dementia, you may experience memory impairment, apathy or lack of interest. Sometimes you may also have depression, and for Alzheimer's dementia, this is a gradual onset. This is a slow process, slow deterioration. So moving on with vascular dementia, this covers 20 to 30% of the total cases of dementia. So this is what we call also little strokes in our brain. What exactly happens here? It is caused by the disruption of blood flow to our brain. So here with vascular dementia compared to Alzheimer's dementia, memory is less affected. And they may also experience mood changes and frailty as well. And here for vascular dementia, unlike Alzheimer's dementia, where it's a gradual onset, vascular dementia is a step-like deterioration. So when you compare with step, it's steady and then down, steady and down. So a person may be experiencing signs and they are stable at the moment, and at some point, they will deteriorate rapidly. Then they will be maintaining, they will be stable at some point, and then deteriorate again. So this is vascular dementia. Next, we have mixed dementia. Mixed dementia, this is dementia for dementia caused by more than two types of dementia. So most commonly, we have Alzheimer's dementia plus vascular dementia. Next, we have Lewy body dementia. This covers 5% of the total cases diagnosed with dementia. So Lewy body, this is actually, again, protein deposits in the brain called Lewy body. And this may cause hallucinations. This may cause fluctuations in cognitive ability of the person. And usually, people who are diagnosed with Parkinsonism and later on diagnosed with dementia are usually having Lewy body as the type of dementia. Okay, now next is frontotemporal, which covers 5 to 10% of the total diagnosed cases. This is actually an early onset of dementia. So this is a damage in the frontal and temporal regions of the brain. It may cause personality and mood changes, and also this may cause speech problems. Now moving on. So let us identify the risk factors that may contribute to developing dementia. So we have, of course, modifiable and non-modifiable risk factors. It is very important for us to be aware about the risk factors. Let's take diabetes and high blood pressure, for example. When diabetes and hypertension is uncontrolled, it will be more likely that a person may develop dementia later on in life. So same also with the other risk factors, such as hearing loss, air pollution, excessive alcohol, depression, head injury, social isolation, obesity, physical inactivity, smoking, and less education. These are also risk factors that may contribute to developing dementia. So next, we have also, if we have the modifiable risk factors, we also have the non-modifiable risk factors. So for age, older adults are more at risk of developing dementia. And as per gender, according to statistics, females are more prone to develop dementia because they tend to live longer. And lastly, we also have genetics. So to sum up the presentation, dementia is an umbrella term for many illnesses that cause progressive decline in cognition, affecting daily functioning, and 50 to 75% of dementia cases are due to Alzheimer's disease, but not all dementia is due to Alzheimer's. So we have to look out for the 10 warning signs and try to address the 12 modifiable risk factors. So thank you very much for staying with me in this part of the presentation. Next up is the diagnosis of dementia, which will be presented by my colleague, Ms. Nisha. Thank you very much once again.
Thank you, Ria, for the wonderful presentation. Hi, everyone. I'm Nisha Sunil, one of the Dementia Master Trainer working in Inaya Specialized Care Center, which is a long-term care facility to take care of the elderly patients with dementia as well. Before moving to the session, I would like to share a life experience of a dementia carer, which will help to understand why this session is really important. The carer was the husband of the lady with dementia. Her name was Julius. She was a master degree holder and she was the active member in her family. And she was working in American Red Cross Society. Her initial symptom was losing her photographic memory. Slowly, her reading and level of comprehension, even her mathematical abilities started to slip. But her husband or the family members failed to understand her initial stage, initial symptoms, and in the later stage, she was diagnosed with Alzheimer's disease. In that article, her husband shared his guilty feeling that if he could have understand his wife's initial symptoms or symptoms in the initial stage, he could have planned to give her a quality life. This might can happen in our family also, or we may hear about this. So this life story reveals the importance of early diagnosis of dementia. Moving on to my topic, why diagnosis of dementia is really important in the life of a person. Let me share my slide. Why diagnosis of dementia is important. I don't have a conflict of interest in relation to this presentation. At the end of the session, you will be able to understand the importance of diagnosis of dementia, acknowledge the existing diagnostic measures, and identify the healthcare team involved in the diagnosis process. So, when to diagnose dementia? Alzheimer's Disease International explains very well about the 10 warning signs of dementia. So, in the earlier presentation, you already heard about the warning signs of dementia. So, once we are aware about the warning signs, once we identify these warning signs in a person, that is the time we have to redirect, or we have to advise the person or the family or the caregivers to the medical team where the proper diagnosis will happen. So why we are saying diagnosis of dementia is important? There are some factors which will help the person to lead a quality of life. Once we diagnose the dementia in the early stage, which will help the person to access relevant information about the diagnosis, and he can access the resources and support from the society. And also, he can participate in the early stage support group, which will affect on the quality of the life of the person as well as the family. And also the person will get enough chance to explain to the family and his friends. He can review the financial situation and he can make the right decision. And also early diagnosis will help to eliminate the potentially treatable conditions. We can treat some conditions like if the person is having diabetes, hypertensive, or any cardiovascular diseases. So these kinds of diseases, we can diagnose it early and which will help the person to treat effectively. And also studies shows that counseling will be beneficial in the early stage of dementia. So these all will help the person to lead a quality life in the rest of his life. So for the diagnosis, there is no specific test to diagnose dementia. Like any other diseases, there is no specific test to diagnose dementia. There are some existing diagnostic measures which will help the medical team to diagnose dementia. So once the person is presented in the medical team, the physician will take the detailed history, physical examination, and there are some cognitive assessment tools, MOCA and FIM assessment tools. So MOCA means Montreal Cognitive Assessment Tool, which will, it is a brief test which will have a 30 questions. And in MOCA, they evaluate the different types of cognitive abilities, like the examiner will assess the orientation, their language abilities, abstraction, and attention of the person. So the scores of the MOCA range from 0 to 30, with a score of 26 and higher, generally considered as normal. The other cognitive assessment tool is FIM test. FIM is Functional Independence Measures. It is an 18-item scale used to assess the patient level of independence in mobility, self-care, and cognition. So it is used by the healthcare professional to assess the grade of the functional status of the person based on the level of the assistance he or she requires. So the scores will range from 18 to 126. So apart from this assessment, cognitive assessment tool, there are some blood test and urine test, blood test like liver function test, kidney function test, thyroid function test, and the vitamin B12 and the folate test to rule out any vitamin deficiencies for the person. And also the doctor will order for the CT scan, MRI scan, and PET scans. So CT will help to check for the signs of stroke or brain tumor. MRI help to provide the detailed information about the blood vessel damage. For example, in case of vascular dementia or the frontotemporal dementia. And also PET scan will help to assess the brain functions and the abnormalities with the blood flow to the brain. So these are some diagnostic measures which will help the team to diagnose dementia. So who all are involved in the diagnostic process? Apart from nurses, there are neurologists, psychiatrists, consultant geriatricians are there, psychologists, psychotherapists are there, occupational therapists, dietitians, speech therapists. Of course, the family and the caregivers are involved in the diagnostic process. So until now, we were discussing about why diagnosis of dementia is important, what are the diagnostic measures existing, and who all are involved in the diagnostic process. So these are the this is the dementia diagnosis and management pathway, which I explained to you earlier. Like once the person is presented in the medical team, they will assess the patient history. There will have some series of test examinations, investigations. Once it is diagnosed as dementia, according to patient's present condition, he will refer to the different multidisciplinary departments. For example, if a person is having any neurological issues, he will refer to the neurologist. Any psychiatric issues, he will refer to the psychiatrist and the other multidisciplinary team according to the condition of the person. So as a summary, I can say, J. Smith said, if we could have had a correct diagnosis even 2 years earlier, it would have given us more time to plan and accomplish the things we always wanted to do. These are some references if you want more details about the diagnosis. So thank you everyone. Coming up next with challenges to diagnosing dementia, especially the nurse's role, by Ms. Larling. Thank you.
Thank you, Nisha, for the presentation. Good evening to you all. Hope you are all doing well. I am Ladlin Shilpa Rodriguez, one of the master trainer for dementia, presently working as nurse educator in Rumeila Hospital. I am a graduate registered nurse. I worked as a staff nurse in Inaya Specialized Center for 8 years with lots of experience and memories. Dementia is all about memories. I am here because of the memories which I had with my grandmom, who was a person with dementia. Rest in peace, Grandma. So today we are going to discuss about challenges to diagnosing dementia, nurse's role. Now I am going to share my slide. I have nothing to disclose. By the end of this session, you will be able to list the current challenges in diagnosing dementia, understand the 3Ds, discuss the nursing care plan. Challenges in recognizing dementia. Dementia and other neurodegenerative diseases are generally incurable and often difficult to diagnose accurately. Early identification and accurate diagnosis can potentially contribute to more effective treatment. Care coordinations. Persons with dementia are seen in different specialties. Example can be in emergency care unit, can be in acute units, and can be in long-term units. When the person gets admitted to the emergency units, it is an atmosphere where patient it may cause more of confusion because the person is not in the same environment like at home. So the nurses in emergency care unit, for them, it will be like they will be focusing more on the patient's condition rather than they will be knowing patient's history. So what happens here is the nurse will only focus on the physiological needs, whereas she will not focus on the person's disease condition. So it's always better to we take support from the MDTs from the initial day of admission so that they can provide them training for them to identify dementia earlier. As always, proper care coordination is very essential for appropriate treatment. Lack of specialized skilled workforce in dementia.
Nurses in HMC are specialized. Maybe there is critical care nursing, palliative care, and nurses, they are very specialized in IV infusion, catheterization, etc. But when it comes to dementia, at present, our nurses are not specially trained to care for the person with dementia. So it's better to arrange and provide specialized education and training to the frontline staff so as to deliver skilled care for our vulnerable population. What matters in dementia is lack of communication. We need nurses to communicate person with dementia. For me, example, for my grandmom, she was in late stage of dementia. I was taking care of her before joining nursing. So that time I was not aware what is Alzheimer's, what is dementia, even my family also. But day by day, when I tried to understand my grandmom, I came to know her needs. Whenever she used to feel angry, her facial expression was changing. So as the components of communication, the non-verbal communication as highest percentage. So try to understand your patient, try to look yourself into the shoes of the patient. That time you will be able to understand the needs of the patient. So lack of standardized nursing assessment tool. Currently, nurses are not having standardized tool to assess person in dementia. So to overcome this challenge, it's ideally to develop an approved assessment tool to early identify dementia by nurses. The nurses can work with OT team, that is the multidisciplinary team. So the occupational therapists, they have a tool known as MOCA tool. So nurse can assist them during their assessment. So delay in early identification and diagnosis by MDT. So diagnosis of dementia is really tricky because many of the disease condition, it will mimic the symptoms of dementia. Example I can give is 3Ds: delirium, depression, psychosis, infection, organ failure, vitamin B12. So regarding this, we will be seeing in the coming slides. Delay in early identification and diagnosis by MDT. So when the patient visits hospital or admits in the hospital, we are mainly focusing on the physiological needs of the patient. But we will not see his past history or what the person is undergoing himself. So this interferes a lot of planning in nursing care. So when it comes to the nurses, nurses should be using critical thinking and nursing judgment in the plan of care. Suppose working in acute unit, when the person admitted there, person with dementia, example I can give, he is agitated. So immediately it's not like the nurse is calling physician, doctor, can you please order psychotropic drug because my patient is very agitated and restless. It's not like that. Always know the person. Maybe the person is having constipation. He cannot verbalize, he cannot express. So if you know your person well, then you can deal with the person. So always put the patient in the center of our care. That is the person-centered care. It's not only focusing on his disease condition, but we should overall focus on the needs which he wants. Myths and stigmas. So it's ideally the family, they will deny and they will believe that the person is having dementia because they will think it is normal part of aging, but it is not. Ideal in Qatar, before they used to get like in the OPDs, they used to get patients, those who are having dementia in the late stages. But now, even the person above 60 years, they will call the clinic and they will ask for assessment. So in Qatar, due to our education, the persons, they are now the family, they are coming forward and they are asking for the assessment. Differential diagnosis of dementia. So as I mentioned to you all before, these are having similar symptoms, but there is variation in finding. So it is difficult for the nurse to distinguish, but thorough assessment, we can differentiate. Examples here are degenerative disorders like Parkinson's disease and Pick's disease, depression, delirium, and psychosis, organ failure, autoimmune diseases like multiple sclerosis, hypothyroidism, bacterial and fungal infection, traumatic brain injury. So we will mostly deal now about the 3Ds. As I mentioned to you all, these all diseases will mimic the symptoms of dementia. So many older patients, they are affected from delirium, dementia, and depression. So these conditions are not part of normal aging. So the 3Ds, they are different from one another. But it can be hard to distinguish between them, their signs and symptoms. So because these may look alike. Sometimes a person has more than one of these symptoms at the same time. So example, person with dementia may be having delirium. He develops delirium when he has constipation. So we will see the difference between the 3Ds. When it comes to delirium, this is acute onset. It occurs during hours to days. So if you manage delirium, you can treat this delirium. Coming to the dementia, it will start insidious. So it will start from months to years. And the depression weeks to months. The course is fluctuating in delirium. When it comes to dementia, this is progressive. And when it goes to depression, it is chronic. So duration, as I mentioned to you all, it's hours to weeks in delirium. In dementia, it's months to years, and in depression, it is months to years. When it comes to delirium, there is altered level of consciousness. But when it comes to dementia and depression, it is usually clear. So attention is not impaired in delirium. When it comes to dementia, it is normal except in the later stage of dementia. But in the depression, it can be reduced. When it goes to the irreversibility, delirium, you can, if you treat it, it is usually reversible. When it comes to dementia, it's irreversible. So we mention it always, early identification, appropriate treatment is needed. For depression, usually it is reversible. Now going to our part, that is the nurse's role in diagnosing dementia. So when the person admits in the hospital, so we have our initial screening and history collection. A thorough screening and history collection can be able to prevent more complications occurring in person with dementia. So observe and report any potential signs of underlying dementia. As I mentioned to you all, early diagnosis leads to better treatment. So always, nurse should have critical thinking and there should be nursing judgment, whichever care she is providing. Nurse should be observant, empathetic, and trusted by patients. Every intervention and interaction is an opportunity to build a therapeutic relationship with patient, so they will verbalize their feelings. So know your patients well. If you know your patients well, if you are able to communicate with them, involve the family with them, you can really make a good progress in the patient condition. A strong nurse-patient relationship facilitates accurate assessment and improved outcomes. Yes, nurses are there with the patients every 24 hours. So the more you will know your patient, the more you will know what it is he is facing. So after the history collection and the initial assessment, we nurses, we are formulating a diagnosis and initiating care pathways, and we are referring to the multiple disciplines. So after the assessment findings, these findings are reviewed by the geriatrician or the psychiatrist. So from them, the final diagnosis is made and the treatment is started. So we have NANDA diagnosis, North American Nursing Diagnosis Association. So they have given some of the nursing care plan for the person with dementia. First is self-care deficit due to cognitive impairment. This usually happens in the later stage of dementia. The he will go to a wheelchair bound or a bed bound. So he depends on his activities of daily living. Impaired verbal communication. As I mentioned to you all, for my grandmother, she was in late stage of dementia. She was not able to communicate. But since I came to know her day by day, I used to understand what she is experiencing. Nutritional imbalance. We have to involve the multidisciplinary team. For this, we have to involve the dietitians. So dietitian will come and assess the client, based on their likes and dislikes, the nutrition can be planned. Impaired swallowing, this is usually, it occurs in the later stage of dementia. So the speech therapist also comes in line. Bowel incontinence. So this is one of the challenges which we nurses are facing in our admissions. Most of the person with dementia, they are coming to the hospital with this condition. So usually they are for poor oral intake. As a reason, they develop constipation, which leads to delirium. So it's not always you're going to inform doctor patient is having agitation. Maybe the patient is having constipation, it leads to his delirium. So if you treat this, the person can become normal. Impaired urine elimination, fluid volume deficit. So these also in our care plan. Disturbed thought processes. So this one usually it starts from the mid to severe stages of dementia. Disabled family coping. If the person with dementia is the head of the family, so the family members, it's very difficult for them to cope. So always involve the family in the plan of care. Disturbed sleep pattern. The person, if he is admitted to the hospital, it is a new environment setting for him. So it's very difficult for him to adjust, and maybe he may not be able to sleep. So kindly know your patient, manage it well. To summarize, nurses can make a difference. Nurses offer a unique contribution to improve living standards for those living with dementia, as they provide a majority of personal daily treatment requirements and embrace a holistic care model focusing on person-centeredness. As I mentioned to you all, person is in the center of care. So do not focus on the condition of the person, but please focus on the needs of the person. We can make a difference. I would like to conclude this session by reading a quote. They may forget what you said, but they will not forget how you made them feel. Again, I'll repeat. They may forget what you said, but they will not forget what you made them feel. So today we dealt about challenges to diagnosing in dementia, understand the 3Ds and the nurse's role in plan of care. So these are my references. Thank you for your attention. Coming up next, existing dementia services in HMC and overview. We have Ms. Marwa and Mr. Karim. So thank you.
Thank you, Sister Leah. Assalamu alaikum. Good evening all. My name is Marwa. I am one of Qatar National Dementia Trainer. I am working in Rumaila Hospital, Geriatric Outpatient Department as a nurse technician. Today, me and my colleague Mr. Karim, we are going to discuss about the existing dementia services in HMC. Let me share my slides. I don't have any conflict of interest. And by the end of this session, you will be able to review the existing services available to diagnose and support persons living with dementia in HMC. Today, I'm going to discuss our services under Department of Geriatrics. Under the leadership of Dr. Hanadi Al-Hamad, she is the chairperson and medical director of Rumaila Hospital and the national lead for healthy aging and focal point for elderly in the state of Qatar. First memory clinic in Qatar, established in Rumaila Hospital in 2012. Our services look after people above the age of 60 years. And during the COVID-19 pandemic, new innovative services were established to ensure the safety of our older adults whilst continuing to provide care. As all of you can see our services here, in the middle we have Raha. Raha is an Arabic word, means comfort. And Raha is our National Alzheimer and Memory Services helpline. It was launched on 15 June 2020. And we are located in Rumaila Hospital, Geriatric Outpatient Department. We are working from 8 o'clock to 3 o'clock, from Sunday to Thursday. We receive calls related to memory concerns, related to physical health issues, and sometimes crisis calls. And we make sure that we connect them to the right services. In 2019, the total number of new patients were seen in our memory clinic were 550. After launching Raha, our helpline, the total number were seen and assessed in our clinic June 2021, 1,600 new patients. At the top, you can see that we have now 13 geriatrics memory clinic, one of them located in the primary health care center, and the remaining are in Rumeila Hospital. Next to that, we have our elderly urgent care unit. It was established in Rumeila Hospital for people above the age of 60 years with medical problems that are not life-threatening but need urgent medical attention. This service offers rapid assessment and care in a less busy and age-friendly setting. Next, we have our geriatric home care. We have our geriatric long-term care units. We have our acute geriatric assessment units. And we have our geriatric helpline and tele-pharmacy. Geriatric helpline located in Rumeila Hospital, geriatric outpatient department. They are working from 8 o'clock to 3 o'clock, from Sunday to Thursday. They receive calls related to consultation and medication refill. We have our consultation services, geriatrics and geriatric psychiatry, in different hospitals, helping our elderly. We have our virtual consultation, and geriatric department was the first department to use virtual consultation in HMC. We do see the patient via video to enable that our elderly patients are getting the medical advice from the comfort and the safety of their own homes. We have our Geriderma clinic, and it is a collaboration between geriatric department and dermatology clinic. We have our geriatric wellness clinic, where they are seeing people with mild cognitive impairment, and it is looking at modifying risk factors and enhancing healthy lifestyles. We have our polypharmacy clinic, where elderly can get review of their medication done by geriatrician and clinical pharmacist. And the services were made easily accessible for geriatric memory clinics and elderly urgent care unit by accepting self-referrals. Here you can see our services. At the top from the left side, we have our Geriderma clinic team. Next, we have our virtual consultation. After that, we have our telephone reassurance program, and it was started when COVID started to call our elderly at the age of 60 and above, asking about their general health and well-being and supporting them as well. Next to that, we have our elderly daycare unit. We have telepharmacy, our Raha, and finally, we have our educational caregivers session to support our caregivers and discuss their needs. Moving to next slide, it is older adult psychiatry services. It will be conducted by my colleague, Mr. Karim. Thank you.
Thank you, Marwa, for your presentations. Good evening, everyone. I'm Karim. I'm a head nurse of Community Mental Health Other Service Outreach Service, and one of the dementia trainers. In addition of what presented by my colleague earlier about the existing services in Hamad Medical Corporations and mental health hospital, we have other adult psychiatry services. We have community other adult outreach service, which is a home care service. Nurses that are going to the patients' houses to assess them. And we have specialized outpatient clinics. We have inpatient psychiatry beds currently provided in adult units. And as well, we have residential service in Inaya Continuity Care Center too for female. As well, we have liaison other adult psychiatry in Hamad General Hospital and Al Wakra Hospital. We have consultation liaison in Qatar Rehabilitation Institute. As well, we have management of behavioral and psychological symptoms of dementia. We call it BPSD clinics. This clinic is mainly run by the clinical nurse specialists with the help of the nurses from community or the adult outreach. And community or the adult outreach service, it started on 1st May 2011. We are operating from Sunday to Thursday from 7 to 3. We are looking after the patients, those who have 75 years and above, as well younger patients with cognitive impairment. We call it early onset dementia. We are looking for the both genders, all nationals and residents. The major diagnosis we are receiving when receiving the referral are looking for patients those who have psychiatric illness arising in later life. Examples like schizophrenia, depressions, anxiety. As well, we are looking for the psychiatric illness first arising in adult years, but continuing into later life, like dementia with the psychosis, agitations, anger, aggression, and delirium. We are located and we have two hubs for other adult outreach. One hub is located in Maidar Anaya Continued Care Center 2. This is an outpatient clinic and outreach service. He's looking for the patient, those who are located in Maidar, and the other hub is in the central hub in the Barwa Tower. It's a virtual clinic and outreach service that are looking for the patients, those who are in central of Doha and south of Doha. Our team is actually, we have 5 consultants, 3 fellows, 2 graduated fellows. We have 1 clinical nurse specialist, 1 head nurse, 1 charge nurse, 9 staff nurses. We have 1 occupational therapist. We have 1 part-time social worker and 1 part-time dietitians. Our goals is to provide a comprehensive multidisciplinary service for patients in need of mental health services, and to provide appropriate and supportive education to the family, patients, and their carers. As well, the patient-centered care is our goals. Always the patient is in the center. All the care plan is tailored according to the patient's needs and preferences. As well, the biopsychosocial approach, we are keeping the consideration of the psychological issues and social issues. As well, you know, most of our patients, they are elderly, more than 65, and they have medical issues. So always we are creating, you know, a pathway and collaborating with other disciplines in HMC, and all our cares for our elderly people is coordinated together. Okay, currently we have in the service 265 patient and outreach service. You can compare with earlier when I told you when we started with only 15 patients in 2011. Now we have 265 patients. You can see the difference, and the demand is very high. Our patients in outreach, our staff in outreach service, they have 30 caseload per caseload. This is, you know, the standard. However, right now we have some nurses who are carrying, you know, 40 patients caseload. In the outpatient clinic for the consultant, they have equal to 90 patients caseload per consultant. Our nurses, their roles in managing patients and looking after the patient in their home and community outreach, they are doing the assessment, supporting patients, family carers, educating the carers on how to deal with the persons who are having dementia and having some difficulties and dealing with the daily living for their loved ones. As well, they have to monitor the physical health needs and coordinate the referral, the appropriate referral for the patients to the right directions. Let's summarize. all the service we have mentioned earlier in the presentations are here, and we're working together, I said, and coordinating to help the patients. And we have Raha. Raha is located in Rumaila Hospital in the geriatric department. And you can see you can call the people from 823, and you will some expert people, they will guide you in the right directions and where to get help and how to get help. And all we are here to help persons with dementia. Thank you for your attentions. Coming up next is panel discussion, nurses' role, responsibility in diagnosis of dementia, which is led by Ms. Jessica.
Thank you, Karim, for this wonderful presentation. And thank you. It was very informative. And actually, all the presenters have done their really great job. And I believe that you all have got a good knowledge about the dementia. Now, looking forward, we are coming up here for the panel discussion. I am Ms. Jessica Nilesh Wagmare, and I am the moderator of this particular panel discussion. The topic for the panel discussion is the same as the nurse's role in diagnosis of dementia. So we all are having a lot of questions popping up. And I thank you for all the participants, those who have registered for this webinar, have given their their questions about what actually they are thinking about dementia. To answer those questions, we are having our expertise panelists over here. So before I go for the introduction, I heartily welcome every one of you. Assalamu alaikum, good evening, and let's go forward for the introduction of our experts. So I take this opportunity to introduce Ms. Mariam Al-Mutawwa, Acting Deputy Nursing Officer, HMC Executive Director of Nursing, Rumaila Hospital. Ms. Nadia Alanzi, Executive Director of Nursing and Midwifery for Private Nursing Services, Home Healthcare Services, and Community Medical Equipment Services. Ms. Safia Saeed Gul Karim, Acting Director of Nursing Education, Rumaila Hospital, Nursing and Midwifery Education. Ms. Rizna Muhammad, Acting Director of Nursing Education, Long-Term Care and Ambulatory Care Services, Nursing and Midwifery Education. Dr. Pravija Manikot, Consultant Geriatric Psychiatric Department of Geriatric and Long-Term Care. Ms. Zanli Lee Fleming Hudson, Clinical Nurse Midwife Specialist, Community Mental Health Services for older adults. Thank you very much for joining this panel. And these expertise will now open for the discussion. So let's move to the first question. How can we empower the nursing workforce to provide person-centered care in specialty of dementia care? What scope and opportunities can nurse have for dementia care in each facility? For this question, I take this opportunity to open the session by Ms. Mariam Mutawwa.
Thank you, Ms. Jessica, and thanks to our great presenter who presented to us, and thanks for the audience and to the panelist team as well. So I'm really interested about the questions. It's very crucial for us and our nursing workforce, how really we can empower our nurses. So let me take this opportunity to talk about what we have to empower our nurses. So if we talk about our national health strategy, which is talking about healthy aging population, and we have our national lead, Dr. Hanadia Al-Hamad, who's leading this agenda. Having the resources in the ground, having the expertise to help and support nursing workforce, to tell them how to deal and how to handle the dementic patient with their carers and the family as well. Having the awareness and education and training, structured training, and it should be multidisciplinary training. It's not only nursing, it's all the health care providers, all the workforce that we have across our health facility. If we talk about security, if you talk about housekeepers, if you talk about anyone providing care for our patients, they need to know about it. So it's not only nursing responsibility, it's everyone awareness and responsibility. So empowering by awareness, like this webinar. So it's everyone a responsibility in relation to that. I emphasize about the expertise, to have expertise in the ground who can help and support, very crucial. When we talk about awareness, it's the public, it's the community, it's the people in Qatar knows about dementia as well.
Right.
So this is very important for us.
That's true. Absolutely. I agree with you. And for this, anyone would like to contribute about?
Yes, I would like to add on what Ms. Mariam has mentioned regarding the awareness sessions, actually. I totally agree with that, because if you want to introduce something, you need to keep people informed about the updates, about the literatures, about the new things in it. So when it comes for awareness sessions, actually, we have to not only focus about the disease as a disease, signs and symptoms and treatment, but we have to think about it in a more holistic way. So we have to think about, for example, how can we provide a dementia-friendly environment? What does it mean? What are the components of it? How can we train people? Because that will not involve the nurses only, but it will involve the caregivers. The caregivers could be private nurses, could be also somebody from the family, could be any other legal guardians. So you need to know exactly when it comes for the lighting, when it comes for the colors, when it comes for the decoration of the environment itself, the different signs that they will be using. Where is the toilet? Where is the kitchen? Where is the bedroom? So all these things has to be actually added into the awareness sessions, as well as when it comes for the inpatient in the hospital setting, we have to be very careful. We have to stress on the proper staffing, because our target is to provide a high quality care for those vulnerable population. If we can't have enough staffing, definitely we won't be able to reach to our target. So proper staffing and expert staffing in the ground is very important. And that's, again, it's a system issue. So we have to think about it really widely. The other thing is that when it comes for the communication skills, now, when I say I communicate with my colleagues, with my physician, for example, with my parents, with my friends, it's different than when I say I'm communicating with the patients with dementia or a family members of a patient who's having dementia. So they need actually to embed a few skills and components in it. They have to be very sensitive. The communication skills actually should be very sensitive. There has to be compassion. There has to be empathy. All
Clear.
these,
It should be
exactly.
clear.
Because all these things actually will lead to the therapeutic relationship. And once the therapeutic relationship is being built, actually, that's the time where you can gain the trust and the cooperation, not only of the patients, but also of the family members. So I think adding all these components in the awareness session will make it really comprehensive and not only focusing on a disease as a standalone disease only.
Yes, Ms. Safia. Right, absolutely.
The other thing I just wanted to add to what Ms. Mariam and Ms. Safia mentioned about the awareness. Once the awareness, as healthcare providers, we raise awareness amongst our colleagues, all the staff who are working within the healthcare sector. This will enable us to raise the awareness amongst the public. And once the awareness among the public, people are aware of dementia, they start talking about dementia, that will in a way help us to tackle stigma. And once the stigma is tackled, it will help us to actually, it will give people the opportunity. The people will actually be looking forward to, if there are any concerns, if they need help, then they will be able to seek help, and they know where they need to contact and how they need to get the help. And that in a way will help with the timely diagnosis. And as the theme for this year's World Alzheimer's Month is No Dementia, No Alzheimer's, looking at timely and early diagnosis, I think, that will definitely help.
Yes. You know what? You have made me to think one particular point about the stigma and misconceptions. So when we look at it, I was just browsing some of the literature in that I have found out, especially into the Alzheimer's UK organization. They were imposing that 62% of the healthcare professional themselves are been having a misconcept, or they are actually incorrectly thinking that dementia is the aging process. It's a part of aging. So I believe the education plays a very important role. What do you think, Ms. Risa, about
Yes,
that?
and addition to that, when we talk about, before come to your question, is that when we talk about the stigma, is the preparedness of the nurses, and this has also to go with the education, as what Ms. Safia said. It's not only to know the diagnosis, because as we all know that the nurses are the front lines. They are the first one who comes in contact with the patient, and they should be ready to face. How about the stigma of the healthcare workers? Are they prepared to face a patient with dementia? Not only that they know what are the signs and symptoms of dementia, but are they prepared to take care? Maybe they have their own family members who are having dementia, and they have a shame of it, and they will not show. So because of this, with this one, they are also ashamed or maybe guilty of taking care of a patient with dementia in the hospital, while at home they have their own parents or grandparents who have dementia, and they are not showing it, or they're not telling anybody. In education perspective, the competency of the staff is very important. We have to see to it that they are competent enough, they're ready, they know what's the signs and symptoms, they know how to have advanced communication skills, the way they treat, they also know how to educate the caregivers, and they have to identify their mental health awareness, because caring people with dementia doesn't take only for one day. It's a lifetime caring. So if the nurses are starting to move on and talk to a patient, and the patient becoming a repetitive, they ask the same question all over again, maybe the staff nurse doesn't have the patient. Maybe our staff doesn't have the compassion or the empathy towards them, and they try to avoid such kind of patient. So in this way, we need to establish that advanced communication skills should be given in an education perspective. We see the competency, and we have to measure that they met their competency. And their mental health awareness, they need also to make sure, talking about person-centered care, to have, for example, helpline. Not our patient to have the helpline. As we understand, we have Al Raha in Qatar, in particularly in Rumaila Hospital, in the HMC. If they know Al Raha, the patient and family caregivers can contact the Al Raha. But what about the nurses? Can they contact if they are mentally burned out in caring our patient with dementia? Do we have do we have the resources that the staff can contact? I'm very tired. For 3 days, I'm taking care of patient with dementia. To whom I will consider? I think, Sandil, can you talk about it, that our staff had the resources to reach out to mental health, for the mental health or the staff well-being?
Okay. Thank you for that, Ritzna. I just want to add on to the dialogue, especially about recognizing burnout, especially in nurses as well as caregivers. That is really important. I mean, at the end of every shift or at the end of the week, it's really important to give each other time just to talk about how you felt, because I'm a caregiver, and I spent quite a few hours in the evening sometimes talking to my friends, just explaining about how I feel and how much, I cry sometimes because of my mother's situation, but I cannot cry with her because maybe she's no longer able to actually feel the things that I feel myself. But the most important thing for me in looking after somebody with dementia is actually for the family and caregiver and the patient to actually have confidence in that, the nurses who will be looking after me actually knows who I am and what do I represent in my life and who I am, as a person. So when that care is being delivered, that care must be full of compassion, must be full of the passion for actually delivering that kind of care. I think in terms of who you are when you're working with somebody with dementia, it's not something that you can just do because you need to have a job. It's not. Actually, it takes more than that. You need to have, the qualities. You need to have the personality. You need to actually have the stamina to actually manage that. It is actually very exacting, and it's also very taxing. So it's very important that, as a nurse, you actually spend time. If you are the allocated primary nurse, make sure that you make it, your duty to actually be with your patient most of the times. And when you're actually on duty, make sure you give that patient regular input. You have conversations with the family. You actually take part and provide information which is going to feed into the comprehensive assessment for the patient. And you also spend time with nominated family members so that they can tell you the story of their loved one. You need to know that. You need to know it by heart. I mean, there's no point in actually, maybe the doctor or another colleague, the OT, the physio, asking you, can you tell me more about this patient? I mean, what is she like in the mornings? And then you say, actually, I don't quite know because you haven't read about it. It's very important to make it your business to actually manage the endorsements well so that you get to know your patient and you can actually, almost give a one-page summary of that patient and say, I know my patient, I know what they used to do, I know their preferences, I know their likes, I know their dislikes, I know their fears, I know their anxieties, and I know what it is, that they actually feel, because take time to ask them the questions. How do they feel? They can tell you. It's really important not to just think that the person with dementia, I want you to be in a position where you see the person, not you actually see the dementia first, but actually seeing the person. That's really important. And just going back to what you said, Dr. Pravija, about diagnosis and the importance of that, you find that a lot of people, when they've had a diagnosis, they actually, one regret they have is that I wish we had been given this diagnosis earlier. They want that early diagnosis because they want to actually have time to plan their lives, to do the things that maybe they didn't do, to put everything in place, to actually put maybe those advanced decisions about how they want to be looked after. If you actually ask a person, with the dementia and say, would you like to go into a care home? You find them saying that, I don't want to go into a care home. My mother actually says, she's afraid that she'll end up in a care home because I won't be able to manage it. But that's not the point, because I always reassure her. But it is very, very important to give them that reassurance.
Absolutely, because in Qatar, we don't have a culture of homes, care homes. We have that our loved one should be at my home. I should be the one who is taking care of my father or my mother, or the one who has been suffering with dementia. So in this community setting, really it's challenging for every one of us. And even as a nurses, the strengthening the workforce, really, nurses has to be strengthened themselves, isn't it? In the person-centered care, it really plays a critical role, I believe, and that's absolutely amazing for
I also feel that if you're delivering person-centered care on a day-to-day basis, you actually experience less burnout. But if you're just treating the place as an institution where care is provided, it actually can become very tiring and you burn out. But if it's really and truly person-centered, you actually see the patient blooming, you actually see the joy in their face, and you actually see that engagement, in them, and it makes you feel good, and you actually feel proud of yourself. And at the end of the day, you can ask yourself a question: what have I done today to make me feel proud? And you can actually say, I saw that little lady smiling today, and she was telling me about how she used to, cook this or make this recipe. I saw that little old man actually smiling at me, and that will make me feel proud. So we should all have our proud moments of the day, but you can only have that if you are delivering a truly person-centered care environment, and that takes a team effort. It's not just one person, it's like a whole team effort, and that includes the family as well. Those are our allies in this journey, and we don't want anybody to travel the journey alone. They must travel, with us together. We can make it.
I think,
Of course.
I want to share one clinical experience here when we talk about the person-centered care. I had one patient in an inpatient setting where he was very restless, he was wandering, he was going through things. And as a multidisciplinary team, we were having discussions, what is happening. And there was a lot of kind of discussion on what medications the person should be given so that he's less restless, he's less agitated, because constantly he's on the move. He's looking for something, and he wouldn't say, he's not able to communicate exactly what he is looking for. And the concern was that, that'll put the person at risk of falls, and so on and so forth. So there was a lot of pressure. And we were actually kind of breaking our head very hard, trying to think what is actually the issue. And the concept of this multidisciplinary team, it's very important. We actually sat down, and we sat down with the patient's family member, and we asked, can you please take us through his life story? What did he do? What was his work? What his likes, dislikes, all those information. So when we got the information from the family members, we spoke to them. He was actually working as a supervisor. So he usually carries a folder with him with all the paperworks. But since he's come to the ward, there is no paperwork. So he's looking everywhere for that particular piece of, for the folder with all the paperwork there. So we said, okay, that's it. We've cracked the code. Let's try. So as a team, what we did, we got a folder. We put lots of papers. We just handed to him, you know. He was so happy that he got his folder. Then he was carrying the folder everywhere, wherever he went. And he would come to us and he'd say, all good, say everything okay, no worries. We'll be very happy. So I think in that occasion, we didn't need any medication or anything. It's just that we got to know the patient more, and that helped us. So, yeah.
Yes,
It's
Dr.
really
Ravija,
important.
it's absolutely fine. And it's a proud moment that we have this concept implemented in Hamad Medical Corporation. And we have a lead as Ms. Nadia, and she can contribute a lot about it.
Actually, we have similar situation in the community, but it have been improved not only in the patient care, it's also in our nurses, how they provide the care to the patient. It's back again, it's education and awareness. As you mentioned, Jessica, earlier, some of our healthcare providers, they don't know what is the dementia.
That's true.
But we focus on it. We attend a lot of education related to dementia. We have the same nurses, we have the same patient, but the delivery of care, it's been changed after the education and the awareness. We don't have, like before, the same misunderstanding, or the nurses, they want to change the patient, he don't want the nurses. We build the trust. And back to the PCC as well. Now our patient and our nurses, our family, they are sharing everything. They are also focusing on each other. We are focusing on the nurse, we are focusing on the patient focuses on the nurse as well. Then now we can see everybody become happy because they understand each other. They know where they are going for.
That's true. Thank you, Ms. Nadia, for that response. You know, we have a lot to talk about dementia, and we are talking. Indeed, we are talking. It's needful to talk about dementia. So this webinar is actually giving opportunity to every one of us to talk about dementia, to know about dementia, to know about Alzheimer's. So as we are progressing forward to the next question, that is, person with dementia develop behavioral and psychological symptoms over time. They may also have mental health issues and other comorbidities. And I think most of the nurses have been exposed to such situations. How can we support them and their caregivers?
I'd like to just maybe pick on what Dr. Pravija said about this particular patient. That kind of leads us very nicely into that scenario where somebody has got the behavioral and psychological symptoms of dementia, which can be quite distressing. And it's usually a reason why people, why family caregivers end up saying that they can no longer do it, they can no longer manage, why they will suffer extreme burnout, because of that, and why nurses will actually say, I wish I could be allocated somebody else, tomorrow, because, today I had a very difficult day. So those symptoms are quite significant, and especially if somebody has got dementia and they're admitted in a general ward setting, that can actually cause a lot of havoc on the whole ward, because the person could be moving from bed to bed and sometimes trying to pull off, all these, wires and everything, and it can be very, very challenging and also very risky. There can be risk of falls. They are walking, pacing up and down, looking for something. And I think sometimes we call it wandering, and it's an easy term to use. But actually, like that man you talked about, he's actually looking for something. But sometimes we don't know what they're looking for because they can no longer remember, but maybe they've been taken back to so many years ago what they used to do. This is why it's so important to remember that in order to manage, this condition, you need to actually get to know the patient. You need to know the patient, the past, what they used to do. What was the person? Who was he? Who was she? You need to understand what was their day like? What was their working day like? If he was a fisherman, what sort of things did he want to do? And, did he wake up early to go fishing? What did he used to do? So it's very important that we try and mimic those routines as much as we can to make sure that we can provide a care that is similar to what they actually used to do. But when it comes to, having these symptoms of dementia, especially kind of combined with other comorbidities, like, for example, somebody has got, maybe diabetes, and they're constantly walking up and down and looking for food to eat, and they find food straight into the mouth. They find, it can become very, very challenging, on the ward. So having the comorbidities, can actually complicate the situation. And sometimes we end up resorting to medication because there's no other way. Sometimes the person becomes so aggressive, which can also be very challenging, especially to families, because they don't want to see their parents in that kind of position, in that kind of situation. I've known situations where the mother had to manage her husband by actually wrapping herself with a duvet. That was the only thing she could do because he was punching and kicking, and it was really, really difficult. And for her to accept that this is my husband, but this is how he has become, it can be quite challenging. So we need to find ways of actually managing that and identifying, their needs. Usually they may have needs which are there but unmet, and needs that we don't know they have. So it's our responsibility to actually discover what are their needs. So we need to fully assess them, and then we need to devise a targeted care plan that can actually manage those kind of symptoms, and obviously review that care plan as time goes on. And we need to always monitor, that situation, and at the same time supporting the families to help them to understand this condition. Like, for example, if you've got somebody on the ward who is experiencing sundown syndrome, where every day from about 3 p.m. until 8 p.m., they have got this constant on the go, asking, being repetitive, maybe becoming aggressive. It's very important that, especially when you're arranging visiting times with the family, try not to get them maybe to visit at the time when they're actually at their worst. Or if there is a reassessment, by the doctor, do make sure that that is actually at a time when the person is actually able to engage, can concentrate. Or if it's a physio who is going to visit the ward for some therapeutic interventions with the patient, or an OT, make sure that it's during the best times, not during the worst times.
Yes, absolutely.
Because they won't be able to engage in any way. So those situations, those behavioral and psychological symptoms can be very distressing. And as nurses, it is our role to actually manage that and ensure that the patients are actually being seen to and provided with the inputs that they really need and desperately need.
Yes, it's not only about the nurses. Yes, Ms.
Yeah, actually, that's why when it comes for the nursing care, it's very crucial that the nurses should be aware or should be talented enough and skillful enough to do the assessment and reassessment. So, for example, there might be some signs and symptoms that might aggravate their behaviors and attitudes. Not necessarily it will be psychological or mental health issues. So maybe, for example, patient is not happy with the meal that has been provided. Maybe the patient is having constipation. Maybe the patient is having pain, but he's unable actually to verbalize and to talk about it freely. So the nurses should be having enough skills on how to do the assessment, reassessment, how to respond to those needs actually. Mm-hmm. And there has to be a dedicated nurses actually for those type of patients. So the patients will get familiar, and therefore it will be easy to have that communication between them actually. So they will feel also comfortable, they will feel safe. And once the nurses are fully skillful, knowledge and skills wise, then that will reduce her or his stress even, because she or he will be able to cope up with the situations even. Yeah.
Actually, I do agree with that. Now we are grateful that HMC implements CHI training, which is also reflected our patient care, to provide the compassionate care and to put yourself in the patient's shoes. Then you will be still understand what he wants, what exactly, why he is stressed, in addition to the skills that you will have it in addition to his disease.
Sure. I think I just want to add here at a patient level, we're looking at a patient-centered care. And also the fact that non-pharmacological management is very important. Mm-hmm. And pharmacological management, obviously, when the risk, is high, where the patient is putting themselves at risk, posing risk to themselves and to others. from a caregiver perspective, to have that support system in place where there are services which are easily accessible. So if they have any concerns, they can just pick the phone and say, okay, this is the issue. Please, I need support. That is important. And also at the same time, to ensure the mental and physical well-being of the caregivers. And at a service level, to have certain services like daycare facilities, respite, so that the caregivers, the person can go to a particular respite or daycare facility, which will keep them occupied, and they can have certain kind of cognitive stimulation therapy and some activities going on. But for the caregivers, it will give them an opportunity to have some respite, to look after their needs, go out, meet with their friends, and so on. So
yes, Dr. Pravija, actually, caregiver cannot be defined in one definition, because caregiver can be anyone, the family member, the neighbor, the friend, the nurse, whoever, the wife. Anyone can be a caregiver who is closely attached and closely involved deeply into the person's suffering with dementia, right? So as we are digging, there are lot of things are coming up, but unfortunately we are really lacking with the time. And this panel discussion hopefully gave a lot of information, and I believe it is exploring a lot of questions and curiosities about dementia. And I believe that you all will not stop your curiosity, or you will not just seize it, but you will explore more and more in detail in future. And I'm really proud that we are having some systems, those who have been working towards the better workforce, the better system for the dementia care. And for this reason, I'm really thank you for everyone to participated, and especially for the experts, panelists, those who have contributed a lot, and they have shared a lot of information and answered most of the questions those who have been actually asked by the participants. Now it's time for every one of us to get ready for the care of person with dementia. I would like to request all of you, please take a few minutes to complete the survey by scanning this code or clicking on the link in the chat box. After this particular session, the certificates will be distributed within 10 working days of this webinar. So don't forget to collect that. And thank you very much. I would like to end with one small poem which has been written. I just Googled it and said that my eyes do not see, my ears do hear. I may still me, so let's be clear. I'm not able to walk, or maybe I may not be able, I maybe have a slow movements, but I am me inside me. Please let not it go. So this is all about the person with dementia, and this is all about the person who care. So it's not about the failure. It's all about we are trying our best. Thank you very much once again.